So it's nice to meet you all. Thanks so much for having me. I really love CMC and all it does. I was supposed to do this talk I think a month or two ago, and unfortunately had a scheduling conflict at the last second. And so it's just great to be here and wonderful to see so many people at the end of a long summer day come and join. So I appreciate it to be as interactive as possible. So if you have questions and you don't mind being on YouTube, feel free to unmute and let me know. I am actually having a little bit of a hard time seeing the chat as it is. So I don't know, Elliot, if you see something in the chat, you can feel free to, the way my current displays makes it tough, but if you don't mind reading it. But if anyone has a question, feel free to unmute and let me go. I'd prefer it actually if you ask me as we go through it. Um, but yeah, I'm John Avery. I'm the vice chair of addiction psychiatry at Cornell. I also run the fellowship. And this topic, the stigma of addiction as it exists in society, but especially as it exists in the medical community, is very, very dear to my heart. And a lot of the reason I became an addiction psychiatrist was because of the stigma I saw with loved ones, and peers that were, being stigmatized for having substance use disorders. And my education timeline is notable for multiple people telling me not to be an addiction provider as I made my way through, college and medical school and then to residency. I was counseled multiple times not to. And fortunately, that didn't deter me, but caused me to lean into it. And so we'll talk a little bit about other people's works and some of what I've noticed in the stigma of addiction as it exists in society, and then talk a little bit about it in the medical community. I mean, one of my big things is that the places that should be the safest to talk about substance use disorder often aren't, and the negative impact that has on folks. So that's the doctor's office, that's the lawyer that's assigned to you if you have legal issues. Sometimes that's us as we deal with loved ones, and it's tricky. So I think it's important we all sit and think about it as much as we can. A few disclosures. Some of this is taken from my book, The Stigma of Addiction, that I wrote with my brother, Joseph Avery. He's a lawyer turned psychologist. He's now a professor at the business school at Miami. You can Google him, and when you do, you might have the urge to say he looks like me, but with hair, which I don't know why everyone insists on saying. I know that's true. This is also supported by a few other grants. Foundation for Opioid Response and a couple other internal grants that have helped support some of the work. Those are my disclosures. A few thank yous off the bat. When I became an addiction psychiatrist, I imagined working with folks with substance use disorder, people struggling. But two groups, I don't know why I didn't think of it in advance, though I've worked with a lot and have really informed a lot of my work on stigma and in substance use disorder. And one is family members, loved ones who are struggling with substances. I think probably the most overlooked group in all of the opiate epidemic. You hear about the 100,000 overdose deaths. How many families are those? How many people are, struggling with the 40 million plus with substance use disorders in our country? And I think they are historically undersupported, under-recognized, and sometimes feel like they have nowhere to go, which is some of the beauty of CMC, of course, with their incredible family supports. And there are a number of other folks recognizing this, but I still feel it is a real deficit. And there's so much to learn. I think I've learned more and grown more as a psychiatrist and person from dealing, from sort of interacting and learning from family members who have struggled. And I've incorporated a lot of their stories in my stigma work, both to help me understand it, but also as a remedy for it. And we'll talk about that. And then I think sometimes people in recovery disappear too. That's the other group I didn't imagine having such a strong impact. Probably more people in recovery than with active substance use disorders in the United States. Sometimes it disappears, especially in the medical community. Once someone's better, it becomes maybe a note in their chart or not the active experience with them. And so they sort of disappear sometimes from a doctor's perspective. And sometimes families and us just want to turn the page ourselves, right? And forget about it like it never happened. And so sometimes we miss how strong and robust this recovery community is and what stories there are to tell. And I'm grateful for their role in all of my work as well. Here's the agenda. We're going to talk about the stigma of addiction, especially as it exists in society. We'll focus a little bit on as it exists among clinicians. Physicians is broad, but it exists in many clinicians, and we'll talk about that. And we'll discuss some of the current efforts, some of the thoughts I have on how we can improve it, both in the medical community and in society in general. And for those that have joined since we started, feel free to interrupt me with any questions. I can't see the chat for whatever reason, but feel free to unmute and let me know. Preaching to the choir about the numbers, you guys know this. No avoiding addiction, the opiate epidemic at record highs, 100,000 deaths in the last year. We're in this third wave where fentanyl is contaminating the drug supply. And I think it's worth noting that it has impacted minorities at an alarming rate, and the numbers are just staggering and sobering. We've almost become immune to them, in fact, and to all the people and families and stories behind them. We'll talk a little bit about how the media is trying to take anti-stigma courses themselves and to describe it in a way, but sometimes the opposite happens. You become so clinical and you saturate so much with it that it loses its meaning and you lose the people behind it. And anytime I see these numbers and the deaths, it's heartbreaking. But there's a ton of other substance use disorders. Addiction's not going anywhere. I think we sometimes overlook benzos. There's youth vaping. There's alcohol, which still wins the game mostly. Here I'm at New York Presbyterian Hospital. We're 9,000 to 10,000 presentations a year for alcohol use disorder, 10 times more than what we see for opioid use disorder. People coming in with the medical consequences of alcohol, about 1,000 presentations for opioids. Alcohol is one that sort of darts in and out of being stigmatized and being thoughtful about and being something that's such a part of our society. And we'll talk about that in a little bit. And then, of course, marijuana. We're seeing more people misuse hallucinogens as we see them as a potential treatment that will help folks on the same token. And I'm sure people have a mix of opinions on marijuana and the legalization, but we've certainly seen the use go up, and they're concerned, and people still end up with marijuana use disorders, of course. The cost of this is all tremendous, not just for lives, but certainly on the economic costs of it, lost work, healthcare, crime. And we've largely spent a lot of money incorrectly and problematically to try to solve it. But it does cost us a lot as well. All right, but we know that. And we know the numbers, and I think if you're here or tuning in on YouTube, you're here because you've been impacted by substance use disorders in one way or the other, either personally or as a clinician, trying to think about how to be thoughtful in dealing with it. And I don't think we can be a thoughtful person, clinician, family member without recognizing the significant stigma that exists towards substance use disorders. And what are we talking about when we talk about this? Addiction stigma refers to the negative attitudes towards individuals with substance use disorders that, one, arise on account of the substance use disorder itself, and two, are likely to impact the physical, psychological, social, or professional well-being. One thesis right at the beginning, I do think our attitudes towards it as a disease model or a learning model, or the degree responsibility plays, does play a large role in how we think about substance use disorders and how it informs our language and the degree to which it's stigmatized. I don't think the disease model of addiction is complete in any way in helping us understand it. But I think the complete rejection of it at times and viewing of it as a moral failing or as something different than doctors and clinicians should pay attention to has driven a lot of how we view addiction, and that's led to stigmatize. Like in society, we put these folks in jail. We don't offer treatment, for example, and even clinicians feel sometimes it's not in their purview. It's something for other social networks to pick up. And so I think thinking about it is always important. And it's always interesting too, because I'm going to present a lot of studies that I've done on the stigma of addiction, on understanding attitudes, a lot of survey projects. But even in medicine and in my studies, which are generally readily accepted, they're pretty low risk and non-controversial and provide some data. A lot of it always ends up being on this conflict around the disease model of addiction, and it even in medical circles, even in research circles, quickly becomes not what you would expect it to be. And I think our mixed views on what substance use disorders are, what the disease model of addiction is, can really impacts a lot of this. And we'll hear this throughout our talk today. Katie.
Sorry, I was on mute. So hi, thank you for being here.
Thanks for having me.
I am someone who has 22 years of continuous sobriety from alcohol and drugs. And when you put this in quotes, I don't believe in the disease model of addiction. Maybe you've already answered this a moment ago, but so the person that's saying that, do they only believe it's that people like myself are morally bankrupt? There's something wrong with us? Is that that's the only other thing? It's either morally bankrupt, degenerate, low life view, or the disease model?
It's a good point, and hopefully not. I mean, there's obviously a lot of nuance there, and the degree that different societal factors and other folks have talked about, which I think are really reasonable perspectives on the role society plays in isolation, like Johann Hari and Maya in The Unbroken Brain famously talks about as more of a learning model, which isn't quite the disease model. Either of them are totally behind in terms of what's causing it. But I think all of them agree that when you're in the middle of severe substance use disorder, change is very hard.
Yeah.
And so there are definitely softer, other acceptable ways of viewing at it. And sometimes it's not just, it's all moral failing. And I think most of the time it's that the disease model of addiction, well, sometimes it is that people think it's sort of not it's different than mental health issues and substance use disorders in a significant enough way where it should deserve medical attention. And I don't know if they would say degenerates, but they might say it represents, something about someone's decision making and what they value, and as opposed to being a moral failing. And so it's important to not speak in all or nothing terms. I agree. And sometimes that can, I'd say most people are somewhat nuanced, but there are people, and I've been surprised, because I've given a talk or a version of this a lot, that do think it is a moral failing and do think the answer is viewing it as something that one should punish one for, even in the medical community. And you see this, and I mean, I've got someone that's almost a teenager in school, and you hear teachers, I mean, it's not that, even as we understand more and more about how substances hijack the reward pathway in the brain and how, change is really hard because of how things are firing and rewiring. And most people know that to some degree, I think, more than they did 10, 15 years ago. There are still people that feel like it's just excuses for bad behavior in some ways. I would say. I don't know. What's been your experience?
I hang out in Alcoholics Anonymous meetings. So, we all, at more than one point in our journey, nobody ends up in AA on the wings of victory, right? So I know I can only speak for myself. There's definitely times where while drinking and having consequences and drug use, I felt morally bankrupt, or I felt that I was doing this to myself. I did not learn about the disease of addiction or the even genetic components until I went to rehab. So I needed to be schooled on it, and I'm in school right now to be in grad school to become a marriage and family therapist with a specialty in substance use,
Awesome.
um, addiction. And I'm really surprised. I'm so surprised at the number of people who still have what I would call a very old-fashioned view of alcoholics and addicts and substance use users, substance use disorder. But so um, I think there's a lot of people out there who know and want to help the community. And I think, as you said, it's very nuanced. It's not black or white, but I've run into both. I've run into all levels, let's put it that way.
Understood. Well, thanks for sharing. And maybe this quote summarizes a little bit of what the experience is at times. Americans love drugs, but hate the people who use them, especially if they're poor and not white. We send them to prison. So let's talk about the stigma as it exists on multiple levels in society that may be informing some of why we think or people think more than we would think that it's a moral failing or bad people doing bad things. I think the media and stigma certainly plays a role. The media plays a role, rather. The research suggests that media often depict individuals experiencing addiction, especially drug addiction, in a negative light. And most causal frames in the media have emphasized individual culpability in explaining addiction. You sort of blame the person instead of the disease or the different societal factors. Surgeon babies addicted to drugs. And nobody does it worse than our New York Post here, full of problematic language and problematic ways that, New York City drug crisis reaches new low, with addicts standing around with needles hanging out of their arms. Commonplace to see a glass-eyed junkie stand in the middle of the Midtown sidewalk. None of that provides any nuance. And, this is from August 2023. This isn't from the 1950s here. So, this attitude is still what we're reading about here. And this language that exists in the media, certainly infuses our common language as we talk about substance use disorders, and does impact how we think about these folks. Language plays a big role in how we behave and act. Um, we're learning to describe folks with substance use disorder as a person with a substance use disorder, and trying to avoid terms like clean and dirty, and sometimes folks who are with substance use disorder find these helpful to really label themselves in this way. But I think the impact's very clear. I mean, for example, when doctors are rounding on patients in the hospital, if they describe the person as an alcoholic or heroin addict versus an individual with alcohol use disorder, an individual with heroin use disorder, they're twice as likely to offer treatment when they describe the person as an individual with an alcohol use disorder. It just changes how you think of it, as opposed to these labels, which sort of, push people away. And they try to teach people in the media and other folks who are communicating with the general public how to use this language, but sometimes they intentionally choose not to make points. And the New York Post is just picking the not that language to be provocative, of course. Of course, the media is broader than just the online and printed press. It's our certainly Hollywood and how it's depicted plays a large role in how we think about substance use disorders. I think it's been better lately in a couple ways. I mean, I don't know if anyone's seen BoJack Horseman. I mean, it's a horse, but he's it's emphasizes the role trauma and mental health plays. Patrick Melrose is a good example of how trauma informs future substance use. And even increasingly, I mean, commonly in movies, like getting drunk is like the answer to everything, every transition point in every movie in the history of every romantic comedy and guy movie. If you have a breakup, you get drunk. If you do something good, you get drunk. If it's sort of like it's almost like a plot device, the intoxication, and it's sort of glorified in that way. But increasingly, people are more sober, and sober curious stuff is making its way even into popular media. I mean, the Smartless guys are notable for a top 10 podcast where Jason Bateman and Will Arnett are both sober and talk about it, and so I think there's some nuance, but it's still any movie you see, there's these days there's still that everyone getting drunk and nothing happening. But you know, we see it, the sober curious and casually mostly sober. Our athletes like Tom Brady, you know, are choosing to not drink. And I've never seen more expensive non-alcoholic drinks than I've seen in the last year. I mean, every menu now comes with, you know, sugar, highly sugar, a lot of sugar in a drink that costs $10. And so, you know, I think that's good. You know, there are bars and there are situations where, um, you know, where it's, you know, I think the attitudes are changing a bit. This is one example where the New York Post was sort of helpful. Vaping can shrink testicles, cause sperm count to plummet, but that's not a great example. It's you know, we're trying to push it in the other direction. All right, so we're talking about the different layers first of society that are impacting the stigma of addiction, and certainly the media and the popular media and the press play a role. Then there's this huge intersection between race, substance use, and stigma. And this also intersects with the legal system, which we'll talk about in a second. But you know, the data for this is really strong that participants assign greater blame to Black individuals who developed drug dependence, drug use disorder, as compared to white individuals who did the same. Black individuals perceive their substance use problems are viewed less favorably than the substance use problems of whites. And these racial stereotypes combined with the drug stigma, it's been found that professionals, even physicians and other folks, view folks in these categories as potentially violent, dangerous, and criminals, low in both warmth and competence. And so you judge folks based on race in addition to substance use, of course. And when they intersect, things can be very problematic, and they can be especially problematic when they intersect then with the legal system. These are two papers I'm gonna go sort of fast through actually, but that I did with my brother, who I mentioned was a lawyer turned psychologist and was interested in the stigma that exists in the legal system. He's now working on developing like machine learning and other sort of using AI strategies to take some of the bias out of legal decision making. And we'll talk a little bit about how that might inform medical medical care as well. But basically, you know, folks with substance use disorders who are African American, other minority groups are disproportionately put in jail. George Floyd famously spent 10 months in prison for $10 worth of drugs during his health timeline. And the bias exists in multiple levels. There's pre-arrest and arrest factors. There's post-arrest factors, percentage of African Americans in prison for drug crimes, not proportional to arrest rates. There's prosecutorial bias, juror bias, judicial bias. And then I mentioned that early on, I'm very interested in bias, like you sort of expect it in some ways in all those places, but I'm interested in bias where you least expect it. And so my brother and I were interested if criminal defense attorneys who are assigned to or choose to work with individuals with substance use disorders may be on some level biased against their own clients. Just like doctors who interact with patients with substance use disorder may be biased against the patients they're assigned to care for. And so my brother and I looked at this, a couple studies. This one was on the disease model of addiction, looked at lawyers. You see lawyers, you know, versus doctors, which are a much diverse group, are predominantly male and white. And we asked the lawyers, which of these do they agree with? All the way from addiction being a chronic relapsing brain disease and folks with substance use disorder have practically no choice, all the way to it reflects a moral lapse. And we showed that there was a pretty broad range of attitudes. You know, most people viewed it as closer to a disease model than a moral failing, but there are a lot of people that viewed it as a moral failing, and our study showed that the degree to which they viewed it as a moral failing, the more negative their attitudes were towards their clients. As you might expect, the degree to which they agreed with the disease model of addiction, the more positive their attitudes were. And we think, although we didn't study it, that likely correlates to the care that these folks got in their defense, right? If you think someone's a moral failing and doing the wrong thing, you're going to change the way you take care of them, which may explain some of those disproportionate sentencing numbers that we talked about earlier. This is an example of sort of one of the vignettes that we might send out for some of our studies. And we've done a couple, and in this one, we we showed that worse attitudes towards those with substance use disorder was associated with greater beliefs that those defendants would commit future crimes. And so, um, there's clearly problem in the legal, and so I have updated slides that I think I didn't take, that I didn't put in. This is still current. Like, this is not like old news. It's gotten better in some states, and less people are put in jail for substance use offense and diverted to drug courts or treated differently. And certainly marijuana being legalized has decreased the number of folks whose lives are wrecked for a low-level marijuana offense. But if you take a look at the data, it's still bad and nowhere near where it should be. And race still plays a role. All right, so there's stigma in the media, stigma sort of related to race and as it intersects with the legal system. There's certainly stigma at work. Like, these days, you can take a mental health day. You can tell your boss anything's going on. I need to work from home. I need to take a day off, a week off, a month off for mental health issues. But it's still very hard to endorse a substance use disorder to someone at work. And getting the courage to take that 30 days off, even if you're protected, is really hard. And it really gets in the way of people coming forward. They're worried if they increasingly you can feel confident, never before, to say, I'm having some mental health struggles. I need to take some time off. But still, it's very rare that my patients and people I know are comfortable telling their bosses of what they're going for. I mean, you're proud about the breast cancer survival, and you're proud of, you're tackling something. Everyone's very forthcoming these days, but substance use is one which it's still not something that we talk about. And I think that plays a big role in the medical field, as we'll talk about in a second. I did this event at the hospital here on the stigma of addiction. It went to all these different New York Presbyterian hospitals, broadcast to everyone. And I wanted a doctor in recovery or a nurse or some other clinician at the hospital to come and to talk with me to the whole folks here. And I know I'm sort of a friendly-faced anti-stigma guy around campus. And so I know everyone in recovery because they come up and talk to me, and 0 people would come forward and talk at this event. No one wanted to be outed as someone who was even in recovery as a clinician. And so that speaks a lot to stigma. And I get consulted a lot for substance use in workplaces, like that's happening in finance or in banks or law firms. And they want me to come in and sort of address the substance use culture. And yet when I go there, it's like crickets, right? No one comes forward to, like, I think the best intervention is when you have someone from that industry or company who says, I've struggled myself. This is me in this business coming forward and seeking help. But it's very hard to get that from these places, and so you end up offering confidential, no questions asked care, and helping sort of shift the HR culture. But the general culture doesn't change because the people working there, no one comes forward and says, look, I've struggled and I've gotten help. I did do one place where the CEO had struggled, and he came out at this meeting and said, look, I'm doing this because I'm someone in recovery. I've never told anyone here. And then we were able to help so many people there get into care. Suddenly it was like a veil was lifted and people are like, all right, we can talk about it. But that's still rare. And it makes it hard for especially our young folks who are starting out and care about promotion and trying to advance to get the help that they need. So there's also stigma in the family. And family is implicated through stigma by association, closeness, unusualness, blame. And I think this is especially true for parents. There's this assumption that poor parenting and poor family values. There's all these problematic terms like codependent and enabling. The Mexican president blames U.S. fentanyl crisis on the lack of hugs among families. It's hard to be struggling and you feel like you can't turn to anyone about it because you'll be judged, right? As opposed to it being a health issue. And why are families feeling this way? Because of the media and because of the legal system and because of the schools and because in their workplace, they know that one guy told it and he wasn't able to work again. There ends up being such a shame, and you blame yourself. I've got a couple kids myself. I'm always like, anytime they do good, it's parenting, and anytime they do anything bad happens, it's genetics. It's tricky to it's tricky to own and understand one's role in anything that happens, and families take a beating sometimes, and then often left to grieve alone, as I mentioned, in the setting of this opiate epidemic and not finding supports. And I'm saying all of this because these stigma on all these levels lead to self-stigma. Like, you wonder why your loved one doesn't want to seek care, or you wonder why people aren't honest about their substance use disorder. You would be nuts to be honest about your substance use disorder. I'm more worried when people come up to me and they're honest, given the stigma that I've just described on all those layers, you know? And the sum of this all is that you then feel that you're a moral failing, and you have the shame, and it's something you hide and can't come forward with. And you begin to identify with all these negative stigmatizing stereotypes that exist out in society. And as I was saying, it situates the individual in a place where recovery is made even less likely and more remote, decreases willingness to involve others and seek treatment. And then in turn, it impacts all these areas we just talked about, right? Your work struggles, your family life struggles, your relationships, your friends struggle. And it becomes this difficult cycle to get out from. Before I shift to stigma in the medical community, any thoughts about or comments on stigma in society? All right, pushing forward. So I expected, for some reason, that doctors would be different, that clinicians would be different. I imagined that they would be walking around with halos on their head and tried and true, clinicians here to do good, but it turns out not to be the case. And my findings and the findings of others are that clinical attitudes are worse towards individuals with substance use disorders than towards individuals with any other medical or psychiatric condition. I have had so many folks who have had negative experiences with their pediatrician, then their internist, and we wonder why they don't seek further medical or support from other folks. It's because these attitudes are very pervasive, and we've studied them and examined them using this medical condition regard scale. There's a couple other anti-stigma scales or stigma scales. This is the one I use most frequently. And we've looked at different groups: psychiatrists, psychiatry residents, different specialties, ER, internal medicine, OB-GYN. Among psychiatrists, ER, internal medicine, OB, the ER doctors have the worst attitudes towards folks with substance use disorders. OB is not far behind. You can probably imagine why that is. You're mostly seeing people in settings of intoxication or withdrawal. The problem with that is that's the entry point to our healthcare system these days. And so again, we have the sort of gatekeepers, the pediatrician, the primary care doctor, and the ER doc with potentially negative attitudes. Add OB to it, and you're starting to get a sense of the problem. Even among addiction and community psychiatrists, when there's complexity like co-occurring disorders, attitudes are negative. We looked at adolescent providers' attitudes towards nicotine and opiate. They were worse than towards diabetes and depression. And this large European study, not done by me, examining primary care, general psychs, even specialist addiction services across Europe, had the same finding. They looked at physicians, psychiatrists, psychologists, nurses, social works. Attitudes were worse towards those with alcohol and drug use than towards any other medical condition. And their finding, like mine, is that older folks had worse attitudes than younger clinicians. And attitudes are worse towards drugs than towards alcohol. Attitudes are also negative towards treatments. Certainly the meds for opioid use disorder get the worst of it. And there remains some controversy even as there's significant evidence around them, but a lot of people have negative attitudes towards medication-assisted treatment of all sorts. Certainly negative attitudes towards 12-step work, though, and rehabs, and a lot of the things that can be very helpful, people have a lot of misconceptions about and stigma toward. This is important, like the stigma that exists in society is important because it results in a reduction in empathy and provider involvement, decreases the quality of care and treatment. People with substance use disorder wait longer to be seen in the primary care office, wait longer to be seen in the ER. They're often not offered evidence-based care, and on and on. So why does this exist among doctors and in clinicians? Well, turns out doctors are a part of society. You don't suddenly go to medical school and become not stigmatized, and it's been shown that to not have stigmatizing attitudes. And you know further, not only do you have the same attitudes as where you were raised, doctors and clinicians are more likely to misuse substances than their age-matched peers. The other part of stigma, and I maybe didn't highlight it as well as I normally do in the beginning, there's stigma as other. Like, I don't understand it. It's a moral failing. It's nothing that could happen to me. The other side of stigma is sometimes that it hits too close to home, right? That you're struggling and you don't know what to do with that. And that translates to not knowing, how to act in general, or you disavow that part of yourself. And so you disavow that part in others. Anne Marie, I'm sorry, you're muted.
Sorry. I work closely with a program where we deploy recovery coaches to the ED since 2017, and it never failed in dealing with medical professionals. I have this theory that somewhere in the ones that have the most crippling attitudes towards substance use disorder patients, somewhere in their past, I feel either a father was an alcohol user, or a spouse that they needed to leave, and it almost always rings true that their own, like, personal, like you're saying, their own personal experience with it created the stigma. I think that's what you were saying.
Yeah. No, and a third to two-thirds of us have substance use disorders in our family. There's sort of no avoiding it. And so I think that does play a huge role often.
Mhm.
Did
Yeah.
they benefit from the recovery coaches? We're going to talk about solutions in a second.
I was going to ask if I know in New Jersey we have a robust grant program that allows us to do this in many of the hospitals. So, but the turnover in the ED is really we're continually educating and always coming up against stigma. But we keep going.
Good. That's what that's going to be the end of this talk, to tell us to all keep going and get and stay together here, because yeah, we need that. And the ER doctors often are burnt out, and they do have a high turnover. I think they have like the youngest retirement rate among doctors, and so it's a tough space to be in. They hate to be dumped on. They're the ones who got destroyed during COVID too. It is first line intake for that. But still, I mean, the thing is, a quarter to a half of admissions to medical hospitals are substance related. It's not an uncommon thing. At some hospitals in the city, it's over 50%. So there's no avoiding it. So surely we're talking about why doctors have negative attitudes. Surely they don't believe it's a moral failing. They probably believe it's a disease model, right? So my brother and I did that same study that we did on lawyers with doctors, asking them the degree to think it's a brain disease versus a moral lapse. We're a little more diverse than the lawyers. But we had worse attitudes than the lawyers, if you can believe it. Compared to lawyers, our attitudes were even worse. When you're worse than lawyers, something's gone wrong. It's one of those general life principles. Sorry if there's any lawyers in the crowd, but and we showed that the degree to which you believe in the disease model of addiction, the more positive your attitudes, the more negative, the worse your attitudes were towards them. Tons of problematic language. I'm actually doing a project now looking at all the languages in our charts, with a focus on OB. And you still see, even as we teach how to do this, there's still a lot of negative language. Alcoholic is one of the most common in charts still. Clean, dirty language. I think people call opiate use disorder more opiate use disorder. and especially in fentanyl, it's sort of gotten rid of like the heroin addict type terminology, but still, there's a lot of negative attitudes. The other thing that impacts doctors is a lack of knowledge and skills in taking care of these folks. You know, we don't do a great job of educating our clinicians on how to handle this, and they feel ill-equipped at times to do the necessary interventions. It's sort of silly, and I'll show you some of the interventions in a second, but there's like 3 interventions in addiction. Like there's some meds for opioid use disorder, and alcohol withdrawal is pretty simple to manage. I sort of half don't believe it. And part of the reason I don't believe it too is that you would think senior clinicians, for having more knowledge, would have positive attitudes, but you know, that knowledge doesn't seem to improve that. Knowledge of how to care for someone with substance use disorder doesn't seem to improve attitudes. But it is true that they get a lack of training. The other thing that sometimes gets in the way of the care is people get nervous around co-occurring conditions, right? That, you know, there's not only a substance use disorder, but there's co-occurring mental health issues. And I was talking about how that's less stigmatized these days, but still stigmatized. And different clinicians feel uncomfortable addressing it. There's often at times complicated medical issues too, right? So we've got medical issues, psychiatric issues, substance use issues, and that can get in the way and make people nervous sometimes as well. And then again, you know, like in society, doctors also can experience racial bias, and especially as it interacts with drug use disorders and substance use disorders. The reason why I think so, what the big finding is that clinical attitudes are worse towards those with substance use disorder, and attitudes get worse over time. Part of the reason they get worse over time is that you don't get a ton of wins often for your regular practitioner. You often remember the person asking for meds or the person coming in intoxication and withdrawal states. And that sort of dominates your narrative. And when people are in recovery, it just becomes like a note in their chart and not your active experience. They're coming back for something else, even in the primary care. And so most doctors actually don't have the experience of shepherding someone to recovery, because it's either happening outside of their care or, you know, 12-step or, you know, specialized providers. And so, you know, that's something we really have to change, because there's very few specialized providers, and, you know, there's so many misintervention points in the medical community because of this. And then there's all this hidden curriculum stuff, and you see this in schools and in the police force and in the legal system. You know, even though, and you see this even in studies on racial bias, like people know all the right answers these days. You know, if someone gives an implicit bias test or a racial bias test on you, you're not gonna, even if you feel a certain way, even they've shown even on confidential anonymous stuff related to this, people still lie. And so, but if you track their behavior, it's biased and negative, and they're still not, you know, they're still not interviewing the person, even though they took all that, got all the right answers on the course, right? And they're still not acting nice in the room with the person, even though they would totally disavow any negative beliefs if I were to ask them. And so what happens in terms of the hidden curriculum is that people pick up on that, right? It sort of becomes the culture. First, we're going to take care of the heart attack and the diabetes, and then the very last person we take care of on rounds is the person with substance use. And it's never said, but it's done, right? Even in hiring folks, I think something similar happens in all fields, in work and everything else. You know, they're not going to say, I'm not going to promote this guy because of the substance use disorder, but they know not to say that. But what happens in practice? And that's a problem. We'll talk about how behavioral tracking is potentially a solution. And spewing negativity for 45 minutes on all the negative impacts of stigma. But I think there's a lot we can do and a lot that can be done. Yes, JD.
I have a question that might seem controversial a bit
Love
and
it.
kind of challenge everything that you're saying.
Mhm.
I definitely a believer in, you know, when I hear stigma, I hear shame.
Yeah.
And I guess I was thinking about recently, just through something I read, was I know we're obviously talking about the downside of it and barriers to treatment for people and legal ramifications. Is there any upside to stigma and shame? Like, does it, and I'm thinking like, for some people, the stigma of being addicted is a deterrent, right, from them like experimenting using. So I'm just, is there any studies or do you have any information on, is there a place for stigma or shame? Like, is there any benefit to it? Or is this kind of, are we looking at it as like all negative and all, you know, the ways that it kind of hinders people, which I definitely am on board with. I'm
Right.
just curious to see if like, is there a place for that?
Well, I don't think a non-stigmatizing attitude is to be okay with substance use, to be clear. You know, there's a way to sort of healthily set boundaries and express care and offer treatment that's different than being stigmatized. You know, I don't think we want to, and there's been a couple of examples of when you sort of over say it's okay to use substance or permissive, that substance use takes over. And, you know, one of the classic findings in adolescent substance uses is that as perceived harm and availability go up, as perceived harm goes down, use goes up. As availability goes down, use goes up. And so we're not arguing for us all to be, you know, using together. We don't want that attitude towards it because these things cause harm. We're just asking to be a little more, to not judge and to, you know, understand why people are using and to offer care, I think. We don't want to give the impression that it's okay. Even the parenting style for kids, you know, it's not the Donald Trump authoritarian parenting style, but sort of like a firm, authoritative one that's sort of loving, but also firm with the boundaries. Um, and and um, and so I think there is a nuance there, and so I think that's ideal. That being said, it is true that sometimes shame does make us do things in better ways. It's a reality. You know, I've felt embarrassed about doing poorly on a test, so next time I study harder, or I didn't like how that presentation went, and so you know, the boss said that was bad, and so next time I did good. But I think too much of that, and we end up in a lot of trouble.
Thank you.
I don't know if others have thoughts on that.
I was actually, when I read it, I was realizing as you were speaking, it was in the context of relapse and the language of sometimes when we normalize things, which is part of destigmatizing them, it can be tricky to normalize for someone to relapse, right? Because then it seems like a viable option. Whereas if there was, you know, kind of more of like a both and approach, like it's not great, it's not something we want to happen, and we'll, when we deal with it, you know, just I don't know. I think sometimes we don't want to stigmatize anything and not have any shame. I just could see there being other side to it.
No, I get it.
Yeah.
I can't, Ellie, you might have to help me. Who's next?
Yeah, for sure. I know you can't see the comments, so I'll just read Anne's comment really quick, who said, ideally, people won't use substances based not on ill judgment, but on what they want for their life.
Hmm.
And then for hands raised, Anne Marie, I saw your hand, but then it went down. Did you want to?
It's similar to what was commented. I think an invitation to change approach practices that people don't normally change because of like things brought down upon them in a shameful or stigmatized way, but because they're offered hope.
Mhm.
It seems to be more, although Janie, I agree. I think that personal shame does move us, like you were saying, Dr. Avery, like, you know, that can move people. But in the approach in the emergency department, it was time and again, people in recovery responding to people laying there with a substance use disorder, being able to say, hey, I've walked in your shoes and I'm here to just someone who you can talk to. And that was the initial help that we offer. Well, the medical team started getting on board and doing our work. And so they approach people and say, hey, you almost died. You know, I don't want to see you here again, which really wasn't a helpful response. So just changing the way they were responding to people. Recovery coaches have people accepting our help. Over 90% of people accept our help, whereas they found the medical professionals in the way they were trying to help people, less than 30% of people were accepting the help from medical professionals. So we are working with them to I loved what you said, that physicians lack the skills to shepherd people into recovery. We need to help them learn those skills of what a good shepherd is, and being kind and curious. But you've laid out quite the reasons as to why we're where we're at.
Katie?
Yeah, I was just gonna say, so I'm a recovery coach as well, and an ITC trained family coach. And it's so interesting to me, the different reactions I get when I'm working with somebody as a person in recovery, talking to somebody who is contemplating recovery. And recovery coaching these days really is, we understand that it can look very different for many different people, that the 12-step model and abstinence based doesn't really work for everybody. We, in the training that I did to become a recovery coach professional, we talk about harm reduction, and we talk about the shame and the stigma as it can be an impetus to change. It's also heavy to walk around with, right? So we kind of hold space for it as the individual describes to you as their recovery coach, like what recovery looks like to them. Again, there's a lot of gray there, and you have to kind of walk the line of what advice you're giving. But when I'm working with the family really, really benefits from the ITC model, as I'm sorry, I don't remember your name, the woman that was just speaking, coming at it, changing the language, coming at it compassionately, understanding that behaviors make sense, your loved one uses because it does this, this, and this for them. And so there's a real difference in my coaching business between when I'm doing family coaching using the ITC model and when I'm doing recovery coaching. Both have stigma and shame attached to them, but I don't see either being real motivators to change.
Thanks. I like that. Mark?
Hi. Well, I see your slide that says, well, what can we do?
Yeah, we're getting there.
Because I don't know if I'm getting ahead of you, and I should let you talk for a second to come back. I don't know how much time we have left. I just kind of wanted to comment on that piece, but do you want to talk first on that from your perspective?
Okay, that's a nice invitation to keep going. Yeah, let's do it. So what can we do to combat some of this stigma? And I focus mainly on things we can do in the medical community, but a lot of this transfers to things we can do in society in general. I'll tell you some of the things I have done. I mean, one is that narratives around substance use disorder are often so narrow, given how they're presented in society. And so a big part of what we've done is invite people in recovery, similar to the recovery coaches in the emergency room. One, provide them a little knowledge and skills. Two, expand the narrative so they have exposure to people with substance use disorder, with family members who are in recovery. And then three, to have some space for them to reflect on their own personal experiences, both with substance use disorder themselves and with their patients. So giving space to this in a lot of ways where it hasn't existed before. And we've been fortunate to transfer these things, not just here at Cornell, but a number of places around the country. We just did it in the Middle East, actually, in the Middle East and North Africa region, which had a lot of stigma. And so a lot of these things have been translated around the country and world that we've done. And a lot of it's just expanding the narrative, telling different stories, giving people the knowledge and skills, and and often having even doctors in recovery that are part of it. We tried to distill this all into a 7-minute video that does play in a lot of these training spaces. You can look at it at substanceusstigma.com. And we studied this video and these interventions. This is on the video, and when we showed it to internal medicine and psych interns, and improved their attitudes with those with alcohol use disorder and opiate use disorder. And we've developed a number of other tools. We have a whole research center here at Cornell on stigma that looks to understand stigma and to develop interventions. And it's not just me, but a number of folks being thoughtful about how to develop these interventions. So we're actually coming out with our own family program in September too. I've also relied on technology just to seem young or something. And we had this nice partnership with MIT. That the other problem we have in educating people on stigma is that it's become all this anti-bias and anti-stigma training. People don't like it, and frankly are rebelling against it in small and big ways around the country. I mean, you can sort of see it gets tied in with all sorts of, I don't want to go too deep into what I was about to say, but the idea is that people don't like these trainings. And so we've tried to create sort of more fun, novel ways. And so with MIT, we just published on it. We have this whole research team with nice pictures like that because they're at MIT. And we tried to, we basically we videotaped interactions between physicians and patients with substance use disorder. We broke them down. We showed them to people in recovery and with active substance use, and combined this with this data that MIT has on what makes people empathic. We developed this app called MedShip that teaches doctors and trainees, and eventually we're going to translate some of it to families on it basically teaches you empathy. And that's MIT and their MIT lab. They believe that you can teach empathy. And I think that's true, even though I didn't quite believe it before. And so our app sort of highlights, emotions as they exist on face. It educates a lot on stigma. And then it helps you practice how this project came to be is that I was giving a talk. And I had this line that I always say to medical students and in general, that my goal as an addiction psychiatrist is to be the friendliest face the patient has ever seen. And I always say, if I can be the friendliest face the patient has ever seen as a bald, middle-aged man, imagine what all you can do with your youth and your hair. Like, the potential is endless. That's like the funniest thing I say. But I was saying this at this conference where this person who studies affective technology at MIT, Rosalind Picard, was in the audience. And she said, that's exactly what I'm trying to do at MIT. I'm trying to teach people how to have empathy in their face, and for people to learn empathy using this technology. Anyways, the app sort of helps you recognize emotions on face, teaches you about stigma, and then it teaches you how to make empathic and caring faces, even when you don't feel it. And it shows the degree to which you can do that. You start to feel that way. And sort of, especially in the era of telehealth and all the Zoom stuff, let me shift this to the middle so I can see myself. So the most empathic face you can make is, and I can never do this on command exactly, but and I have the eyebrows for it, is a slight eyebrow raise in the middle and a slight non-smiling smile like this. That's like the most compassionate listening face you can make. And the degree to which your resting face can be like that, it's actually been shown that you feel more empathic. And it's sort of like body language. We teach doctors, sit down with the patient, not stand above them. But potentially there's ways that we can train ourselves to have a stance of openness and compassion towards folks, when otherwise we might unconsciously create, tension in our face. And otherwise, that folks with substance use disorders, again, they're totally queued up to detect stigma and judgment, right? Because as it exists throughout society. And they're in a very vulnerable position with a clinician, finally telling their story or being caught with a medical issue. And so if we can teach people to be welcome and open, then that potentially has a lot of benefit. Even if it's a gimmick, it highlights something that's important, I think. You know, it sort of highlights stigma in a way that's, I think, interesting and unique. And so we're working on developing it. And then eventually it teaches
I
you
have a question about that.
yeah.
I was just curious about how, when you look at a intervention like that into how clinicians are interacting with patients, how do you think about balancing their affect with also, you know, the stigma they still might have internalized? Because I could see a situation where they have a welcoming affect and then the things they're saying are actually quite stigmatizing or shutting people down. So where is there, I'm curious as to how you guys thought about that in the development of that tool.
It's sort of like people worried that learning motivational interviewing will you know cause you to manipulate people in your life, which is sort of true actually. It's how I get my 10-year-old to go to bed at night. But yeah, they've been pretty clear, and they've tried to control for it, that if you do have these expressions, you start to feel it, you start to internalize it. And if you're making the active effort, most of the time people are doing it because because they've learned something and want to, you know, convey it going forward. I suppose with anything that can be good, it could be used for bad. Any skill set you have, you could turn it for evil. And you know, the best criminal is one that doesn't seem like one, I guess, right? The So it is a key point, and it does speak to a point I was trying to make earlier about you might get all the right answers on this test and know the right things to say and do, but really it's your behavior being tracked over time and so that's what we're going to do next actually with this intervention is right now we did proof of concept and now we're studying if it improves attitudes over time. And then we're going to really look with all these interventions, you have to look at the behaviors. You know, are they offering treatments to those with substance use disorder? Are they taking care of them in the right way? Because I do worry, as I said with the other trainings, that you know the right answer, you know the right face, but then you're acting poorly, and that's no good for anyone. That's also why we need policy. We'll talk about policy in a second to inform good behavior. So you do need these guardrails for good behavior, even as people have the skills to be master manipulators, I guess. That's a good point.
Thank you.
All right. So that's the first category of interventions, and the ones I'm most active in here is increasing awareness of and interventions for substance use. You know, there's a number of other things we have to do, and maybe I'll go a little quicker here, Aiken. One, we have to address physician substance use. I mentioned we use a ton of substances. We don't accept care ourselves. We have it in our families, and so you got to treat the treater before you help others. And you know, I think we need to do a better job of creating environments where people can get care, and it can extend that to the workforce, right? I think we need, I argue that in places of business, you need a no questions asked opportunity to seek substance use care and know it's going to be paid for by your health insurance. If you don't have that, it's very hard to ask for and get care. If you know when you work for this company, if you need to take time off for substance use care, just tell HR it's totally confidential. You have the time off, you'll have your job when we come back, no questions asked. You know, that's the sort of thing that I think is really important. We've talked a lot about the intersection between race and substance use. And we need interventions that address race, ideally in better ways that, you know, pay attention to outcomes. And that's what my brother's doing with lawyers. He's using AI and I forget all the different ways you talk about that technology, but you know, machine learning to take some of the decision making out of being a lawyer, where you know you plug it in and you know what your expected outcome is for the crime charged and for everything else. So it's less decision making. Part of all of this is that we need sort of a diverse workforce. But I'm not arguing just for diversity in terms of backgrounds, but I'm arguing that we need people with substance use disorder. We need, instead of screening out, hiring folks with substance use disorder, we need to be hiring them more and promoting them for it. I mean, in a workforce, a workplace that champions people in recovery, just like people are championed in breast cancer recovery and in all other sorts of you know, health challenge. Like if you've overcome a health challenge, it's in your personal statement and it feels like a real strength. And you know, I think we need something similar for substance use disorders. In terms of medicine, we need enhanced clinical training programs. There's only something like 1,200 addiction psychiatrists in the whole country. There's none of us. And there's like 2,000 to 3,000 addiction medicine folks. We're still way understaffed for the crisis that we have. And that contributes to care being either expensive or not as accessible. Is certainly a need. We need positive hidden curriculums around substance use. I talked about increasing the knowledge and skills. More practical ways to talk about language and the disease model of addiction. There's so much great stuff out there about the biological model of addiction, and our knowledge of it's growing each year. Nora Volkow, who heads NIDA, does a great job on that. And great treatments exist. I think we need to, even more than learning about them, clinicians need exposure to 12-step work and need to learn motivational interviewing. They need to meet the families. They need to meet all of you and hear what you're doing in terms of your journeys. And that narrative is really missing, and that causes a lot of trouble. And there's good meds that can assist, and doctors like to give meds, and so it's helpful to know there are some that can help. I think harm reduction efforts are helpful, and we do a lot of Narcan kits, and we've coupled giving out Narcan kits with stigma measures. And for example, that was sort of the most successful thing I did with ER docs, is when we gave them Narcan kits to give to folks, it improved their attitudes, because suddenly, they're so action oriented. If they can have something to do to give someone, they feel better about it. And so we saw, this was a study in our emergency room. We did it pre-pandemic. It was published in 2020 though, that showed after the rollout of our Narcan program in the emergency room, that attitudes improved towards our patients with opioid use disorder. That people felt there was more that they could do to help. Fentanyl test strips and xylazine test strips are, in the same family of interventions that can potentially be helpful. As I said, I think an important part is learning at the outset, is learning from the recovery community. I mentioned they're involved in our in-person interventions, and if you watch the video we have on substanceusstigma.com, you'll see how predominantly they're featured there. We have a number of other videos and things, and we have folks in recovery. We have peer programs in our hospital, peers that round with us in the hospital. No one recovers alone, and you need people and others that have gone through it, and you need a menu of option for folks, right? Like, some people want to talk to a bald middle-aged psychiatrist. A lot of people don't want to talk to a bald middle-aged psychiatrist. They want to talk to younger folks who have been through it, and families want to talk to other families who have been through it. And so you need that menu, so that you're meeting the patient and family where they're at, and they know that they have resources and people they can identify from and help. And I think we need more exposure for everyone to meet these folks so that they can benefit. And then along those lines, I sort of said this, talk about families. All of this is good, but I learned that you need to also force good behavior. And so, I think our schools need policies that say don't kick out every kid who's using substances, because that's not helpful for anybody. And we need policies that encourage care and not punishing people on so many different levels that exist in the medical community. It's all well and good that I go around preaching when I preach, but we have to enforce good. We have to, if this is the evidence base and this helps, then we have to be doing it. And sometimes you need policies and procedures to make sure that that's done. I think Starbucks famously saw that around racial bias, that they could put all these trainings in place, but if they didn't track behavior, that behavior didn't change. And to your point, Elliot, earlier on the effective technology issues, is that if you don't track it, it doesn't change. We're tracking in our charts now problematic language, for example. And the interesting thing about problematic language in charts is now patients have access to their charts. You all can see your medical records now, where you couldn't 5 years ago. Super interesting how that's changed, how we document and talk about folks. There's so much more transparency these days because of it. And then I think we all need to be out there talking about it. All of you, me, in the schools, tweeting, Instagramming. Speaks to my age. What else should you be doing? Other stuff, I think. But we have to be out there. We have to be out there spreading the word. Even if you're watching this on YouTube, probably you need the next generation social media intervention to view this. This needs to be cut down into short clips with some poppy music, perhaps. But we all need to be out there spreading the word and talking about it. But Mark, what else should we be doing? What did you have in mind?
Yeah, well, I'll tell you. So first, I wanted just to share a quote. There was an editorial in a recent issue of the journal Stigma and Health, and so just this one sentence. It says, "Quote: Our effort needs to be focused on the public out there who does not really care about stigma and will turn attention elsewhere when browbeaten instead of engaged."
Yeah.
And I love this, and this is the reason why several years ago I began writing a rock musical about addiction that addresses stigma as well, because any good addiction events going on this weekend said no one ever. And so by creating an opportunity for people to come just because it's theater or because they heard the music is really good, and then once they're there, and we presenting addiction in a way that is not generally the way anybody thinks about it. We had already kind of a world premiere, and we've done a lot of rewriting since then, but people would come up to me later and say, not only do they still like the music, but they were still thinking about the show. And nothing spreads the word better than music. And so really believe that this gives an opportunity for people to get engaged who otherwise they're not going to come to any kind of event, or they might not be at some place where you're going to be talking. And so we're excited about the potential opportunities about what we can accomplish. So this is a vastly different approach than what a lot of other people are doing, but I think has the potential to change the conversation by engaging people who are being browbeaten and otherwise wouldn't be engaged.
Yeah, no, I love it. I think that's great. And you'll have to invite me. That sounds awesome. And no, that's exactly
we're hoping to come to New York. Yeah.
nice. That's sort of why, like the smart list guys I was talking about earlier. I've had guys come in to seek help just because they saw that, Jason Bateman said he was in recovery, or Brad Pitt said he was, or they saw the movie Beautiful Boy, or we do need more stories and events and narratives out there that aren't all everyone's dying, but that they have messages of hope and how people get care and provide rounded, thoughtful narratives
Exactly.
and have a little fun too. Yeah, what's wrong with having fun?
Entertain them and educate at the same time.
That's possible. Katie.
Hey, yeah, I love that, Mark. I want to know all about your project. That sounds awesome. Your musical. We in my own local recovery community and on Instagram and other places, we're kind of breaking the rules a little bit of Alcoholics Anonymous, where anonymity was always the core principle of AA. And it's understandable why in the 1930s when AA started, and in the 40s and the 50s, and even later on, even today, till today, people want to keep their alcohol or substance use problem anonymous. We have people now, like we hashtag like recover out loud, because it really is about getting the message out. And I had that life, and then I've had this life, and this life is so fun. Like, it's so fun to be sober and not wake up hungover. And that is the story that that's why we go to other meetings, and why we have open meetings, so people can come in and hear about it and hear the good. Like, hey, I survived, I got out, and it's so awesome. My life is awesome.
Yeah, no, I think that's great. And then certainly being anonymous at times has a role, especially, but I do think the less anonymous people are, I think the better in a lot of ways. If we can get it out there and people can see more folks who are in recovery and not feel like so alone in it.
Yeah, especially younger people,
Yeah.
they just, so yeah, so thank you. That's it's so important.
What's next? Well, music, hopefully, and being cooler about it. We have another lot of ongoing studies further understanding stigma and clinicians' attitudes. I think technology is sort of me trying to be cool and combat stigma in some ways, and I think there's a role for it as well. In medicine, though, I think we have to expand resources for the development and education of addiction-focused clinicians, not just addiction providers, but everyone. And then, yeah, a whole menu of treatments and people and places and things to go to that will, bring this out, I think is ideal. And that's all I got. Let me stop my share. How do I do that? There we go. Any final questions for me today?
I actually had one.
Yeah.
I was curious about in your personal experience or in your research in the medical community, have you seen or how have you seen attitudes and stigma towards family members change over time? And has there been a change in that? Because it's certainly something we talk about a lot in this community is stigma towards family and the idea that it's their fault if their loved one is struggling or all the different messages that families can get.
I sometimes I meet people who feel super supported and got lucky and found sort of a welcoming community that helped them as a family recover. Most of the time, though, I have to say the story when I see people, especially for the first time, is families pretty knee deep in shame and stigma and really not sure where to turn. Like it's amazing how many people, even now, when a loved one's struggling, are just totally crippled by not knowing where to go and having a number of doors shut in their face before they can find something that's effective. And I do think it is getting better. I want to believe it's getting better. But it's slow as molasses. I mean, the stigma to so many other conditions has like gotten so much better over the course of our long battle with this, from cancer used to be stigmatized, HIV, on down the line. And yet, I don't feel it necessarily the degree to which it is, but there's definitely, I mean, the fact that we're having this talk and CMC exists and all of you are out there, I think is different and better, but it hasn't been quite as robust as I would like. I shouldn't still be giving this talk. I should be have moved on to something else or something like that. I feel. Amanda?
Not really a question, just appreciation. I'm in Australia and I feel like you're saying it's moving so slowly. I feel like we in Australia are behind, the US and Canada in our attitude here. And I face shame and stigma for doing what I do as the loved one. And now I'm like out loud, I guess, in my work. And I experience shame and stigma in doing my work and speaking out about this. So it's so multifaceted. And every day, sometimes I just feel so browbeaten, into standing up and doing and advocating and speaking out and owning my truth and speaking out. So I just want to, it's a huge gratitude to come here and it's just given more fire in my belly to keep going and to be more, do more here. I don't know if it's anyone else in Australia who's 100% doing what I'm doing. Obviously there is smart recovery, but no family members really speak out here. So I feel like we're even decades behind, the US and Canada. So thank you so much. It's been just what I needed. This week has been hard. So just appreciation. Thank you.
Well, I think you're what we need too. Thank you for fighting the good fight for us and fight down there. I know how hard it can be. And it's hard. I mean, it is hard. I mean, the joke in my family is I was so quiet growing up that I didn't say my first word until I was 25. And but there's something that just compels one when one sees the stigma and suffering to really want to go out there and to do the good work. And it encourages me as well to hear that you're doing that there. So thank you for that. Oh, that's a pretty good end. That's a pretty good note to end on. Elliot, thanks for having me. Thank you all for coming today.